Now, with that housekeeping done, we hand the floor over to Dr. Sood to begin today's deep dive.
Thank you, Janice. My name is Anubha Sood, and I lead the Total Care Program for Parkinson's disease at the O'Donnell Brain Institute at UT Southwestern. The Total Care Program delivers educational resources, personalized care, and a supportive community for families that are navigating the Parkinson's disease journey. To participate in any of our events, virtual or in person, please look up our webpage. I did put the link to that in our chat. Also, I would like to request you to provide us feedback about this event. So I have also added a link to the feedback form, and you can send us a feedback about this or this particular event, or what you would want to hear more about through the Total Care Program in that feedback form as well. Before we begin, I would also like to thank our generous donors, including the Riecke family, who have made the Total Care Program and this very important educational programming possible. Now I'm delighted to have with us Dr. Jenny Riecke, a Neuropalliative Care Specialist, and Brooke Laplante, a medical social worker, who are both here at UT Southwestern Medical Center. They're going to talk to us about how palliative care can provide crucial support for you to live well with Parkinson's disease. With that, Jenny and Brooke, welcome, and thank you for sharing your knowledge and expertise with us today. Thank you.
Thank you so much for the introduction, and we're both happy to be here today. I need to thank Brooke, first of all, for not only helping put the presentation together, but also she keeps me in line when we're in clinic. But today we're not in clinic, and we get to tell y'all kind of about what we do. So we have a fairly brief presentation, which feel free to interrupt with any questions along the way. And then we hope that there will be some questions from y'all after that we can try to answer. So as we've already said, the kind of title of today's meeting is Palliative Care as Supportive Care in Parkinson's Disease. There we go. So I thought that first of all, we could start with what is palliative care from kind of a zoomed out view. And the reason I wanted to do that is because we see a lot of patients in clinic, and I like to start every new patient visit with kind of two questions. And one is, what did the doctor who sent you to me tell you about why you're coming to see us? And do you know anything about what I do? And the answer almost, I'd say 99% of the time is patients have not been told anything and they have no idea what palliative care is. So I thought we could address that first today. So I apologize, but I'm going to give you a little bit of history because I want to point out how young and how new this field is. So palliative care really started as a movement in the 1950s, so pretty recently when we think about medicine. And it started with surveys of end-of-life preferences in people in the UK. In 1967, we had the introduction of hospice, and it was actually a facility that was built, again in the UK, with about 50 beds. And then in 1972, we kind of had some of this energy coming over to America. And one of the kind of mothers of palliative care, Elizabeth Kubler-Ross, actually testified at the US Senate Committee on Aging, talking about death with dignity. In 1974, we had the first hospice in the United States, and it was Connecticut Hospice. And then in 1997, which is, 40 years after this energy had started, really not much progress had been made. There was a Gallup survey in America that showed that most Americans would want care at home or with hospice services at the end of life. However, most also didn't even know that these services existed before taking the survey. So palliative care is separate from hospice, but we can't discuss it without discussing hospice because that was kind of where it is born from. So when we talk about palliative care, it's an even newer concept. The term itself was coined as late as 1974 by Dr. Balfour Mount. He ended up starting the first palliative care service at the Royal Victoria Hospital in Montreal. And then there was a national hospice organization, and it incorporated palliative care in the year 2000, so only 24 years ago. The first clinical practice guidelines for palliative care came out in 2004. And research findings actually really supported the implementation of palliative care in 2007 when they saw that hospice saves money and people actually live longer with it. 2009 was when hospice and palliative medicine actually became an ACGME training program. And that meant that there's opportunities for doctors to get training in this field. Prior to that, it was doctors in other fields just expressing interest. So that's kind of the background of where it came from. What does palliative care actually do? So palliative care, and this is from the National Institute on Aging, is focused on improving quality of life for people with serious illnesses and their care partners. It is available to people of any age who need it, not just older adults. The major elements of palliative care include, I think I just fixed that, include managing a person's symptoms effectively and ensuring that their care is coordinated. So a couple things I want to point out there is there's a misconception that palliative care is only to be utilized late in a disease, but really it can come in at any stage of disease where extra support is needed for a patient or their caregivers. Palliative care can also be concurrent with curative treatments. Seeing a palliative care specialist does not mean that you stop any of the treatments you're already receiving. So neuropalliative care, I talked about palliative care and where it came from, but those resources were really primarily used for patients with diseases such as cancer. Neuropalliative care is an even newer field. So in 1996, the American Academy of Neurology, which is kind of the governing body of neurologists, said that many patients with neurologic disease die after long illnesses during which the neurologist acts as the principal or consulting physician. Therefore, it is imperative that neurologists understand and learn to apply the principles of palliative medicine. So that's when we first got the energy in the field of neurology to really focus on these parts of medicine. In 2014, there were only 51 neurologists who were board certified in hospice and palliative medicine. At that time, you didn't have to do a training program because the training programs were so new to take the boards. So a lot of people were kind of grandfathered in. Since then, and the data I have is only through 2021, there had only been 160 hospice and palliative medicine certificates issued by APVN, and that includes those 51 in 2014. So it's a pretty small field. Now, how is palliative care delivered to patients? There's multiple different ways. When I shared with you that statement from the American Academy of Neurology on the last slide, that was talking about how neurologists who are already interacting with these patients need to learn about palliative care. And that's called primary palliative care, when you have someone who's not a specialist providing some of these tenets of care. You additionally have specialty palliative care, and that's what I do. I've done extra training in supportive medicine and palliative care to be able to deal with some more complex cases. And then there's a newer movement for something called home-based palliative care. And this is something that's not really widely available, but there are some companies, primarily hospice companies, who try to bring some of these palliative care medical services to patients in their home. So what are we doing at UT Southwestern? So this is something I'm really excited about. We started a neurology palliative care clinic in July of 2023. So it's available for patients who have a primary doctor within our neurology department or our geriatrics program. We hope to continue to grow and be more widely available, but growth is something that takes time. So we're getting there. Since we started in July, we've actually seen 131 unique patients. So it's been pretty big growth. And we have 21 patients with Parkinson's disease. We have an additional 18 patients with Parkinson's related diseases. And those are things like PSP or corticobasal degeneration. Now, one reason why I'm really excited about this is when I was in training here, patients with neurologic disease were able to see palliative care, but the only services were within our cancer center and access was a little harder. When you look at the number of referrals before, it's pretty low. It was growing, but it's pretty low. And when you look at 2020, there were only 55 referrals, and we've almost tripled that in our first year plus change. So we're really enabling more patients to access these services. So why do we need neuropalliative care? Why is it better than just one palliative care clinic for patients with all sorts of disorders? Neurodegenerative diseases, many of my patients share with me that it's really a chronic course. It's something that we're dealing with for years. And it's hard to prognosticate. It's hard to say what's around the corner. People who are trained in neurology have more comfort with the neurologic diseases, with what to expect than people who have not received that training. We also see in some of the diseases that we manage that there's a greater change in cognition, or that change in cognition happens much earlier in the disease course than they would in non-neurologic diseases. I also believe that there's some unique psychosocial needs. So these may be seen in diseases like cancer, but they're just a little different for our patients. Sometimes our patients or their families are having to care for them, and there's an early loss of income, loss of autonomy, a need for 24/7 care that you may not see in another medical illness, and really kind of an early loss of complete independence. So these are things that we kind of help patients navigate. So why aren't there more neuropalliative care specialists? If you look online for other neuropalliative care near us, there's not really any. Really, one of the big barriers to clinical implementation is there's just not a lot of providers. There's also limited data as to how to help patients. A lot of it we're kind of learning from our patients as we go. Now, how do we develop that data to find out what's effective? It's through research, but there's barriers to researching our patient populations as well. And one of them is we don't really have good outcome measures. I don't have a way to prove that something is helpful. That being said, there is a lot of research going on. The left side of this line is 1952 and the right side is 2024, and each bar represents number of publications per year. So if you search for Parkinson's disease and palliative care, in the last 5 to 10 years, there's been a huge growth in the amount of data and evidence out there. And I think that will help us continue to grow this field further. What kinds of things are people researching? And I'm going to talk about research a little bit because I was told that this was a deep dive. So we're diving deep right now. So researchers are really looking into how do we assess patients to find out who would benefit from palliative care and in what ways they could benefit. And those are called needs assessment tools. So can we develop a survey that a neurologist gives a patient? They check some boxes and we can say, yes, this patient should see a palliative care specialist and will benefit from it. What are ways that we can assess quality of life? These are difficult because sometimes we have very long surveys that have been validated for things like cancer, but they don't really apply to our patients with Parkinson's disease. There's also been a lot of descriptions of how people are doing this around the world. So we're starting this clinic here, but there's been clinics started at other academic institutions. And so people are publishing papers about what their care models look like. An area with a lot of room for learning is caregiver burden. How does a patient's disease affect their caregiver, and how do we improve quality of life for both of them? And then an interesting thing that I'm going to go into more on the next couple slides is when we think about research in medicine, we frequently think of things like drug trials, where you give half the patients the medicine, you give the other half a placebo, and you measure something that's very easy to measure. You can't really do that in palliative care. So how do we study these things? We do try to look at some quantitative data, but we also do what's called qualitative interviews to try to learn from a patient population in a different way. So I want to show you an example of 2 papers that were published very recently. So this one is in a really big journal, JAMA Neurology, which is exciting that palliative care literature for patients with Parkinson's is entering these larger spaces. But this looked at patient and family outcomes of community neurologists, palliative education, and telehealth support in Parkinson's disease. And this is trying to target the limited number of palliative care providers and finding unique ways to provide the services without the whole team. So what they did, and you can ignore the part at the bottom, that's just the citation, is they trained community neurologists. They taught them about palliative care. They did like an 8-hour course and said, these are things that you should know about so you can provide primary palliative care. Those doctors also had a palliative care specialist that they could call for coaching as they encountered difficult cases. And they were able to refer patients who were dealing with a lot to multidisciplinary telehealth visits. What they found was patients who were seen by one of these neurologists who had training in palliative care, even though it was just an 8-hour course, they were more likely to complete advanced directives and designate a healthcare proxy, and they had improved quality of life scores for patients. They didn't see a significant difference in caregiver burden. Now, a note, this study had been completed previously in academic institutions as opposed to this as private practice neurologists, and they did show some more benefits with that. Now, those were the quantitative methods, right? Where we measure something and put numbers on it. We can learn a lot more in these studies by doing these qualitative interviews. So this is the same study, just a different paper, where they looked at, is it helpful and what can we learn from interviews with patients? What they found from patients was patients who were not receiving any palliative care, they reported some unmet needs. And some of the things they reported were that their neurologist was overly focused on just their motor symptoms. So just their things like tremor, bradykinesia. They felt that they weren't getting enough counseling about prognosis of their disease, about what to expect. And they felt like they weren't receiving team-based care. They would hear the words team-based, but they were just seeing a neurologist. They felt that they needed more psychological support, and they thought their doctors weren't talking to each other. They also noted that there was a lack of a care coordinator, and because of that, the care partner ended up kind of assuming that role. They felt like they were getting delayed responses from their doctors, and they thought that there weren't enough movement disorder neurologists out there. When they talked to them about what they thought the benefits were from these doctors having some palliative care training and exposure, they said that they felt they were receiving more of a multidisciplinary approach and that it addressed more of their needs. They thought that there was better facilitation of direct conversations about the future. They felt a greater engagement with their healthcare team. And they found that they were getting increased referrals to other providers as well as community-based resources. Now, we always want to ask questions, what can we do better? So when you get that feedback link that Dr. Sood was talking about, make sure you fill it out because we want to hear that too. But some of the areas of improvements that patients in this study talked about were they felt that these community neurologists, even if they got that palliative care training, they may not incorporate it into their practice that much. They want even more guidance about what to expect in the future. So even though that got better, they still felt it wasn't good enough. And then they were confused about who to contact because they had multiple members of the team and there wasn't that care coordination role. So we can stop and take a deep breath. That's the end of kind of the history of palliative care and what it is as a big picture. And now we want to kind of talk about what do we do for individuals who come into our clinic. So I put typical in quotes because there is no typical clinic visit in our clinic. We see people at all different stages of life and disease. But some of the things we always make sure that we address are symptom management. I find with my patients with Parkinson's, a lot of times constipation is a huge deal. Sleep can be problematic, and then issues with appetite, mobility, pain from increased tone, things like that. We also kind of worry about the psychosocial aspect of things, which Brooke will talk a little bit more about in a minute, but how are people doing on a psychological level? How is the caregiver doing? Spiritual health is something we talk about because that really affects our outlook and our expectations when we have a serious disease. And then also, how are things going at home? Are there gaps that we can try to come up with creative solutions to? Another aspect of what we do, so that's kind of all the symptoms we talk about, is we talk about prognosis and planning for the future. I have a lot of patients who Parkinson's isn't their only issue, and they're seeing a bunch of other doctors and need help kind of figuring out how it all works together. I try to really get to know my patients and their families and what's important to them. Given the serious circumstance that we're in, what is our priority? We then can discuss risks and benefits if there's a particular intervention coming up that we're trying to decide if we should do it or not. And then I try to work to coordinate with other healthcare providers too. It's hard when patients feel like they're the person in the middle between their healthcare teams. So we try to cut out that middleman and have those conversations directly if it'll be beneficial. So I'm going to hand it over to Brooke.
All right. So the role of the palliative care social worker, I meet in clinic with Dr. Riecke so that we can build that rapport together where we complete a psychosocial assessment just to help determine what resources or what areas of support are we lacking to help fill in those gaps. I also provide with Dr. Riecke the supportive counseling. We're dealing with a difficult diagnosis and life has changed in many ways. So we're there to support and to hear out what the struggles are with each individual patient. Also here as a resource guide, I know we are limited in some areas, but like Dr. Riecke said, just coming up with creative ideas to help fill the gap when it comes to resources, and then an advocate as well. So if you're working with different clinics, different resources, I can help kind of coordinate that and advocate for you so that we can get you what you need. All right, and then a very important thing that we talk about is advanced care planning in Texas. So we all discuss medical power of attorney in our appointments with patients just to make sure that that form is filled out. We also discuss if there's already a medical power of attorney completed, do you have a second agent listed on your medical power of attorney? The reason that this is important is because if your first agent is not reachable, we don't have a second contact. And we want to make sure that you're having those conversations with both agents to make sure that your end of life decisions are being met appropriately. Another big thing to discuss is when does medical power of attorney come into effect? Medical power of attorney comes into effect when you are no longer able to make your own decisions. So that could be cognitively, or that could be you bonked your head and we're in the hospital. So different situations that it comes into play. But as long as you are able to make your own decisions, that medical power of attorney does not come into place. Now, if you don't have a medical power of attorney and that's not something that you're interested in, I also like to discuss the next of kin decision making based on Texas law. So who would make your medical decisions if there is no medical power of attorney? Now, some patients are completely okay with the next of kin decision making, whether that be their spouse or all of their children, but it's always good to have that conversation so they know who would be making their decisions for them in the event that that happened. All right, so resources for help at home or with caregiver support. A lot of conversations that we have is about private caregiving. Private caregiving is typically custodial care, so day-to-day assistance with activities of daily living, bathing, eating, dressing, things that you need help with on a day-to-day basis. Typically, this is an out-of-pocket cost for private caregiving. But there are some other options for you if you have something like long-term care insurance, connection with the Veterans Administration, or there are some Medicare Part C plans that have insurance benefits that include caregiving, though it's typically limited. The support for caregivers that we're able to provide is connecting with support groups, connecting with individual counseling. We also have a very close connection with the family therapy clinic where they are specialized in medical therapy and can do family sessions as well. We discuss respite care, so what that would look like for someone to go into a facility or to have caregivers come in, and just discussing the overall importance of respite when it comes to caregivers. We also want to leverage the support through the communities that you are involved in, whether that be church, friends, family, knitting group, anything that we can make sure that you're really receiving support.
So this is a question we get asked a lot, is when is hospice appropriate? And we usually have to start it by kind of addressing some misconceptions about hospice. As I talked about very early on, when hospice was created, it was a place that people go to. But really now hospice is a benefit that occurs at home. There are options for being in a nursing facility or things like that, but those are a lot of out-of-pocket costs typically. So patients will ask me, when should I get hospice? And we like to clarify first what it is. Hospice typically is a few nursing visits to your home a week. Maybe an aide might come for an hour or so, but there's really only a few hours a week that they're physically there. But what hospice is it's kind of a way to stay at home if something happens where we need medical support. The only requirement for hospice is that someone reasonably has a prognosis of less than 6 months with whatever disease they have. It's not a requirement that you never go to the ER again or don't want medical care again. That's the only requirement. But I'll tell patients that the recommendation is that it's really only a good service for you when your goal is to stay at home and focus on comfort-based care. And the reason for that is the main thing that it provides is access to a medical team 24/7 if any sort of crisis comes up where we're worried about unmanaged symptoms. So it helps keep people at home instead of having the only option be the ER.
Okay. So choosing a home health care agency or hospice. So through Medicare, you have informed patient choice, and this is just making a decision based on information that you know. We always encourage families to speak with several hospice agencies before making a decision. Now, this can be right before you go on hospice, or this can be months or a year before you go on hospice of making a final determination of what hospice agency you'd like to go with. I encourage patients to have a list of questions when they reach out to hospice agencies on what services they provide, and just making sure that what is important to you at end of life is discussed during this meeting. Um, I also wanted just to put this in here, understanding home health versus private caregiving. Um, so home health is for a skilled need such as physical therapy or occupational therapy, and insurance does cover this. And then just to circle back, that private caregiving services is custodial care that most insurances do not cover. But I also encourage interviewing several private caregiving agencies just to make sure that your specific needs are met.
I unmuted myself. Okay, so we just dumped a lot of information on y'all, and we're really excited about what we do. So sometimes we kind of overload people with hearing about it. But if you want to learn more about kind of palliative care in Parkinson's, I have two really good resources. One is there's actually an International Neuropalliative Care Society. And the International Neuropalliative Care Society is newer. It's only a few years old. But what's different from a lot of the other medical societies out there is it's not just healthcare providers. They also incorporate patients and caregivers into the society because we're helping build the field by using those perspectives as well. And on their website, they have information about different diseases, different resources, and Parkinson's is covered pretty well on there. The others is Parkinson's Foundation actually has some pretty good information about palliative care. The link is really, really long. So the easiest way to find it is just get on Google and type Parkinson's Foundation palliative care and it'll pop up. And there's a lot that you can explore there. That's all we got. And we appreciate y'all listening to us, and we're happy to take any questions that you might have.
Thank you so much, Jenny and Brooke. This was really excellent. I do have a lot of questions, but I'm going to open it up and see if anybody else may want to ask a question. And in the process, I just looked up the International Neuropalliative Care Society link, so I'll put that on the chat as well. Okay. Would anyone have questions? You can also type them or you can share them here as well. Okay, I'm going to start with one then while people are thinking. You did say, Dr. Riecke, that palliative care is kind of very helpful at any stage of the disease. But you also said, there's no typical needs that people come with very diverse and different needs. If you could give us a sense of, how the Parkinson's disease journey goes, what would a newly diagnosed patient, if they were to come to you, look for versus someone who's in mid stage or in advanced stage. So, if you could give us a sense of what it would look like if they came to your clinic.
Yeah. And that's a really good question. We find that one of the things that we can best provide in earlier stages of disease is discussion about prognosis, as well as kind of eliciting any particular values or viewpoints the patients have on what they might want for their care in the future. And the reason I say that is, as doctors, and I spend half of my time in neuromuscular medicine as well, so I'm not always wearing my palliative hat. When I'm not wearing my palliative hat, we sometimes do a really good or a really bad job of planning for the future and talking about what's around the corner. We worry more about diagnosis and immediate treatment. And so in early patients, we typically spend a lot of time talking about what the future might look like, what hurdles might come up. As Parkinson's progresses, as many patients and caregivers know, the symptom burden grows. We tend to have more issues with sleep, with constipation, maybe with pain. And so as we see patients with later stages of diseases, we're talking more about the symptoms, but still trying to continue to wear that prognosis talking hat as well. Later in disease, sometimes we play more of a role where we're helping people make decisions. We find that patients often want a recommendation from their doctor. And so something that we do is we help learn about the patients and their values, talk about what options are available, and help them determine what plan kind of fits their values the best.
Great. We have Daniel Novak, Dr. Novak here with us, and he is saying that, yes, prognosis is a huge issue, that needs to be discussed more. So it's just a comment. I want to put it out there. And then, I have Alicia Phipps from DAPS, the Dallas Area Parkinson Society here. And she is asking about family counseling services available to the general public, or does somebody need to be a patient at UT Southwestern to receive these family counseling services?
I think I saw Connie on the call, so I'm not sure if she can answer that. I'm not sure if she's in a place where she can chime in right now either. But I don't know the answer to that.
Yeah, let's give her a minute. But Connie Cornwell, who is a medical family therapist, and she runs the Family Study Center here at UT Southwestern. They provide family counseling and family therapy to folks, and I will let her speak about it more, but I do know that you can call in and get an appointment. They're always super busy, but yes, you can. From what I understand, you can get an appointment even if you're not a UT Southwestern patient.
That's what
and
I
Connie
understand
hopefully
as well.
Yeah, Connie will.
Yeah, and I put the link in
thank
the
you,
chat
Brooke.
as well.
Yeah, I'll pop in here. I'm sorry,
Okay.
I showed up late. Yeah, our number is 214-648-6945, and we serve the whole community. You do not have to be a UT Southwestern patient. We have actually many of our clients are from outside the system, so it's there. We have hours on Tuesdays and Wednesdays, and we have late appointment times. So people can call the number, and then, our CSA will explain to them more about our services, and because people need to know that it's interns under supervision that are providing the services. And we have right now, I'll be honest with you, I have an intern who is at the UT Southwestern ALS clinic, and she has several of those patients and family members that she's working with at the Family Study Center.
Excellent. Could you give us the number again, Connie? I'm going to put it up.
Sure.
Yes.
It's 214-648-6945. And also we're located at the THD, UT Southwestern THD has kind of this marriage, and we are over at what is the Presbyterian Hospital main campus. We're located in Building 5. So we're right off of Greenville and Walnut Hill in that area, because people need to know that too. Now, with some of our ALS patients, the intern is actually doing telehealth because it's hard for them to get in.
Yeah. And we really recommend that service to a lot of our patients because there are benefits to, seeing a psychologist that you're well established with if you're dealing with things like anxiety, depression. But when we have a new disease diagnosis or struggles surrounding a disease diagnosis, we find that a lot of our kind of community resources that used to be really helpful might not be as experienced with addressing some of the things that we're dealing with right now. And so we've gotten really good feedback from patients on their group.
Yeah. Oh, thank you, Jenny, for that. I appreciate that feedback because, the illness impacts everybody, not just the patient. And and as family therapists, everyone is included in that process.
Yep.
Thank you.
I just want to put a plug in here that Connie Cornwell actually did one of these virtual deep dives with us back in July. And we have our videos from that conversation available on our webpage as well. I have another question here. I don't know if everyone can see the chat section, but Karen asks, can you address non-Medicare insurance coverage for palliative care for younger Parkinson's disease patients who may not yet have Medicare?
Yeah, and we see patients regardless of what their insurance is. As long as it's in network with UT Southwestern, it's in network with me. I think, though, I might let Brooke address things like home-based Pally or hospice, how they're covered by private insurance versus Medicare.
Yeah, so for the palliative care outpatient clinic visits, it's billed the same as a regular specialist. So if you have a copay when you see a specialist, that would be what you pay when you visit us through your private insurance. So with coverage for hospice, it's a lump sum through your private insurance or Medicare. So typically, as long as you have health insurance, you have access to hospice. For home-based palliative care, there's just limitations on the funding for palliative care services. So sometimes the palliative care is like a donated time. So they have a limited amount of spots through the hospice agency that's providing those palliative care services. So it's not necessarily billed through your insurance for home-based palliative care.
Thank you, Brooke. We also have another comment from Dr. Novak. If Dr. Riecke, you would want to read it and comment.
Yeah, so I think he's pointing out that the primary value that we add for people with Parkinson's is conversation, someone to talk to and interpret and validate what they think they heard during the 15-minute doctor dump. And I think that is a good description of a lot of what we do, is helping patients work through what they know about their disease, making sure that knowledge is complete, and making sure all their questions are answered about now and in the future.
Okay. I'm thinking about what questions I have here. Please chip in, anyone, if you have questions. Let's see, I was looking at my notes here. You did mention, Dr. Riecke, about, you actually had that article, the paper that presentation that you made about how there are certain, unique psychosocial needs, and that qualitative study kind of brought those up. If again, if you could speak to us a little bit about young onset, and that's something that a lot of our community folks, ask about. That's, something when they hear palliative care, they're thinking hospice and all of that, right, in their heads. But then, especially for our younger onset PD patients, what do you think their unique psychosocial needs may be, and how you're able to address those with your team?
Yeah, and no, those needs are huge. And I hate to belittle non-neurologic diagnoses by talking about how unique our needs are, but I really think that they are a little different. And some of the things that we see in younger onset neurodegenerative disease like Parkinson's, for which we don't have a cure, is we see an early loss of income. People might have to quit their job and might not have sufficient retirement savings, and it's a chronic disease. So we know we're going to be living with this for likely decades and requiring a lot of care during that time. So there's a huge struggle with planning for that financially. A lot of times there's young kids involved in how do we talk to kids about this? These are all things that we help people kind of navigate through. And I think those are kind of the biggest things that are a little different in our young populations. Obviously, I would love to hear from anyone else who has another perspective on that as well.
So in terms of like resources out in the community, are you aware, Brooke, that there's particular things that we could be offering our young onset PD folks?
We're limited. There are things that we can talk about for future. So, how do we apply for Social Security disability? When should we apply for Medicaid? Do we qualify for Medicaid? What services would that bring to us? So I try to just try to keep up to date as much as I can with what resources are available, but the financial part of it is just not something that I've been able to find a solution to yet.
Yeah. And then we encourage patients to be involved in support groups. But I also tell patients the support group is supposed to be providing you support. And sometimes we have patients who come back from support groups and it's more of a stressful experience for them than a helpful one. And so we try to help patients kind of cater their involvement in those resources to what's really beneficial for them as well.
Thank you.
Can I add something?
Yes.
As the caregiver of a young onset PD
Yes.
patient, another really big area that is, to my knowledge, not addressed at all so far is transportation. I mean,
Yes.
John
Yes.
stopped driving 7 years ago, and he is 61 years old. So that has been a huge, not just a burden on me, but a burden on him, because it limits his social activities. It limits, all the things that like were his hobbies and all that kind of stuff. Most of that requires transportation. And at least in this area, that's a problem.
Correct.
And if your spouse, i.e. in this case, me, works full time, it's a challenge, because then when a person is kind of stuck at home, if you can't find good solutions for that, now we're talking about depression, we're talking about, deconditioning. I mean, there's a lot of issues that are strictly stemming from the fact that they can't drive.
Yeah, for sure. And go ahead.
Yeah, there's really limited transportation benefits in the DFW area. In Dallas County, there is the DART paratransit, but unfortunately, the time is not always reliable. There's traffic, there's other things that come up. So it's just something that we don't really have any control over. And DART is not accessible to everyone location wise. So there's just navigating that transportation is difficult. There are some community programs that provide transportation, but I've found that that's most likely found in the more rural towns instead of in Dallas. So I know that that's an ongoing issue.
So one of the services that we started offering at DAPS last year was a virtual support group for people with Parkinson's. And so I've got a licensed therapist who leads that group, which does help in some regard for those that aren't able to get to a location that they might need for a support system. But that has been a we've definitely heard people say that that's been helpful. It still provides a little bit of that confidentiality and that anonymity for folks who might not be ready to see some people face to face. And so just recently we kind of piggybacked on that idea, and the same therapist is now offering a care partner support group that is also virtual every other Friday. And so that's also just as an option to help people that are in that position where they might not be able to leave home at a certain time, or it just, the day might not, turn out the way that folks have intended it to. So we're definitely seeing some good feedback from folks in terms of getting some of that support that they need from a virtual capacity.
That's great. It's one of the few, well, the only good thing that came out of the pandemic is people know how to do this now. So I'm glad that's opening some more resources.
We have a lot of construction noise here, so I'm trying to talk less. But I've been putting some online on the chat. I've been putting some online resources. So just now I put DAB support groups on there, and I let Dr. Riecke and Brooke read the comments there. We have one from Marcia. I'm going to mute myself.
Okay. Yeah, so Marcia shares that they've lost 3 Parkinson's friends recently. I'm sorry to hear that, and didn't know that they were near death. We had no means to support them in their final days. How can we help others in our local Parkinson's community when they might be needing a friend? And first of all, that's a very thoughtful question to ask. So I appreciate that. And sometimes the only thing that we can offer people is being there for them and being present and listening. It's not an easy question to answer. But I would say that, if you have friends or family members with Parkinson's, just making sure that they're aware of some of these bigger foundations and groups in the community, so that as needs arise, they can try to find some sort of solution to them is one of the best things you can do.
I think also in those situations, you can just ask them, I'm here to help you through this time. What's something that I can do to make you feel supported?
Go ahead. I just want to add to that is that oftentimes we don't, we're not in a position to have that conversation because the patient has now secluded with their family and caregiving, and they're not able to engage with us like they used to. So maybe there's some way that we can develop a help me now kind of button that said, like, I'm the person with Parkinson's. My husband has been helping me for years on this topic, and I want to safely be able to tell him when it's time that it's time, and let other people know it's time.
Yeah. And I think it's very good that you're having these conversations with your care partner about things that concern you about the future or worries that you might have. That's one of the most important things that you can do, because unless you've made other arrangements through a medical power of attorney or things like that we discussed earlier, your care partner is usually going to be your voice if you ever are unable to be that for yourself. And so it's important that they know your wishes and your values.
Thank you for doing this presentation.
Thank you for joining.
Do we have additional questions, comments? Just want to remind everyone, we will also have the recording of this particular conversation on our UT Southwestern Total Care webpage. That link is also available on chat. If there are any questions or comments or concerns about the Total Care program, please reach out to me or Janice King, or you can also write to OBI Total Care Program at utsouthwestern.edu. Once you attend a program of ours, you are a participant in the Total Care program. So, you know, we will be sending you regular information about these educational events as well as whatever else is going on in the community. The Total Care program is here not to generate a lot of its new, stuff, but really do these deep dives and, really connect community to our Parkinson's patients and caregiver community as well. So thank you so much for being here. Dr. Riecke and Brooke, if you have any last comments or thoughts, please do share.
Yeah, no, just thank you for letting us join. It's really good to be able to talk about what we do.
We really appreciated you being here. Thank you everyone for being here. And please do fill out the feedback form because that's what makes this work keep happening and for us to know that you like this and you want to hear more. Thank you very much.
Bye, y'all.
Bye.
Bye.
Bye.